I am being recorded, and I am at Case Western Reserve, which is in Cleveland. They told me, don't come back. So I've been coming to folks from my spare bedroom in Stark County, Ohio, for quite a long time. My focus is working with adolescents, really with multiply occurring areas of need, complex areas of need. When I started at Case Western, I was coming out of providing intensive home-based treatment in Summit County, where it sounds like many of you are right now, and was hired initially to consider co-occurring needs in adolescents, co-occurring mental health and substance use. And with an increased focus on that in terms of coordinating with programs that provide those types of services, really began to expand the conceptualization and the view. And so that's what I'm going to talk about today. So when somebody shows up with talking points and slides, you don't want to see this many words on a single slide, right? That bodes very well or bodes very poorly for the direction of the upcoming discussion. That, oh, she's going to read a whole bunch of words off these slides. I don't have the skill to reduce this to a smaller snippet. This is coming from the promise of adolescence, realizing opportunity for all youth. This was put out by National Academies of Science, Engineering, and Medicine. It's a few years now. It came out right before the pandemic. It is the most condensed single source, focusing very specifically on the uniqueness of adolescence that I'm familiar with. It's a great reference. If you provide services for adolescents, I would recommend, if you are not already a member of NASEM, which is free, it's federally funded, just become a member and download this and just dip into it occasionally. There's a lot of different topics. They're all very easily accessible. And it's a really nice reminder for all of us about the uniqueness of this period of life. Coming from the opening summary, so and it grows from there. But this is just a reminder, and this is the way I'm going to frame my considerations today, that neurobiologically, adolescents have a lot going on. If you were following along, you thought I was going to read this whole sentence, right? Neurobiologically, there's a ton going on. Quite a bit has been settled and set and practiced and put into place by this age, but then there's this whole new spurt of neurodevelopment that's taking place. Interestingly, the second most active period of brain development in our lives occurs during adolescence. Nothing compares to infancy. And it seems logical that it would go in a stair-step fashion down from there. The infancy to toddlerhood, preschool age, school age, whatever. And the development would just slowly decrease as we aged. And then you get to be my age and it goes in the other direction. But during adolescence, there is so much going on in terms of connecting the way that they are going to consider themselves in adulthood and the way they can manipulate information, problem solve. They're practicing all of these things in those cortical areas. We think of the prefrontal cortex in the way that they are planning to move into adulthood. And certainly that's not a conscious planning, but it makes adolescence, right? If you work with them, if you have them, if you're not that far removed from it, you remember a lot of variability during adolescence, and it's perfectly normal. That's the way it's supposed to be. But as we move into what I'm going to talk about today, as we consider them, especially as we consider them diagnostically, it's easy to mix up or forget the expected variability with adolescence with the standardized way that we consider really understanding folks. And adolescents don't fit into that mold all that well. So the second paragraph here, maybe I will read this and then I won't, ramble in different directions, and I'll just stay on topic. Consequently, adolescent brains are not simply advanced child brains or immature adult brains, but have evolved to meet the needs of this stage of life. Indeed, the temporal discrepancy in the specialization of and connections between brain regions makes adolescence unique. The developmental changes, heightened sensitivity to rewards, willingness to take risks, and the salience of social status, propensities that are necessary for exploring new environments, building non-familial relationships. Adolescents must explore and take risks to build the cognitive, social, emotional skills necessary for productivity in adulthood. I think that brief paragraph really sums up nicely. It serves as a really good reminder for all of us that provide supportive services, direct services to adolescents. Neither child brains nor adult brains, they are in a unique stage of life. And I like that it points out that it's a purposeful stage of life. It's not in between anything. It is a very purposeful stage. So I'm going to consider co-occurring and then expand beyond that just a little bit, the co-occurrence of mental health and substance use. And so our starting point on that, very simply, it's when a mental health and a substance use disorder occur at the same or almost at the same time. More individually and specifically, this is coming from SAMHSA and CSAT, when at least one disorder of each type can be established independent. And every time I say that, I think it should be independently of the other, and it's not simply a cluster of symptoms resulting from a single disorder. And I think that it's something that we know, but then we consider in different ways. And perhaps it's more fitting when working with adults, but when working with adolescents, if there is drug or alcohol use, we consider that. If there are mental health needs, we consider those. We consider them independently, but we cannot consider the whole independently. I'm going to talk about that in just a moment. As I talk about adolescence, and this is part of, I guess, the evolution of the way that I conceptualize and consider things. The longer I work with adolescents and the more I have, I've moved away from using disorder, especially as it applies to substance use. Certainly there are areas of mental health needs that fit into that probably has more of that deeper-seated connotation, not necessarily lifelong. Certainly we know that folks can recover from, be in remission from mental health needs or disorders. But during this period of life, because of all of the great plasticity during this period of life, the really, in borrowing from that NASAM publication, really the promise of change during this period of life, I don't think anything is written in stone. Even kids who are in very difficult situations from high trauma backgrounds where they have a laundry list of historic diagnoses. And the most current diagnosis is conduct disorder, because they've just aggravated everybody so much that they're just going to label them with conduct disorder. There's still a lot of promise. There is a lot of hope for healthier trajectories with the right kind of support and the right kind of interventions. So there's nothing wrong with the term disorders. It just, to me, it feels a little bit more chronic or lifelong than saying need. So it's really a semantic exercise on my part, I think. But especially when I'm considering substance use, we've really started using they have needs because it offers, I think, a greater promise, a greater opportunity, recognition of the ability for change here that can be lifelong, that can be very impactful. So as I mentioned, when I moved into my role at Case Western, I was tasked very directly focus on co-occurring disorders for adolescents. And I think I already knew this in practice, but with ongoing work and working with programs that support youth and families, it becomes more and more and more apparent that when there are co-occurring needs, there's a substance use and a mental health need. And often that predicts, as soon as there's those two, that predicts more. In working with adolescents especially, and I'm guilty of saying that a lot, I say especially for adolescents because I consider them, that unique period of life is very separate. And so I say especially for adolescents a lot. But I think in consideration of these overlapping needs, it really is an especially for adolescent consideration, because adolescents have, over covert, I guess I would say, and sometimes overt expectations that they are supposed to listen like children, but think like adults. And there's so much going on developmentally. They have involvements in all these different domains in their life as they're practicing and is moving into adulthood. They're moving away from family, increasing the importance of peers and social connections. Hopefully a lot going on in school, although, if you work with adolescents with multiple areas of need, that school isn't always the domain that it should be. And there can be community contacts, good and bad. Sometimes that involves juvenile justice. And as we consider more and more needs that are impacting a child, impacting a youth, juvenile justice, the likelihood increases. Also, with all of that swirling around, when there are needs on the substance use side of things, when there's needs on the mental health side, or sides, plural, of things, often we see a history of trauma, whether we're going to consider that as developmental trauma, as it's frequently conceptualized, individual traumatic experiences. And once this is all in the mix, that we're considering mental health, substance use, and historic trauma, both developmentally and individually, then it predicts ongoing mental health needs, increased likelihood of substance use, and increased likelihood of being exposed to traumatic incidences. So to work with adolescents, you are working during the period of life, supporting folks during the period of life when we know that half of all lifetime experiences of mental health needs become recognized. I don't know if it's fair to say this is when they start. The foundations might have been there, it might have been there before and it wasn't recognized, but this is really when it becomes recognized. Half of all lifetime experiences of mental health needs arise during this period of life, from puberty through the early 20s, or as it's often considered, like 12 through 18, although those strict boundaries don't necessarily work. Half of all lifetime cases begin by the age of 14. The tasks of life during this period, are learning how to be an adult. And you practice it in a lot of different ways. None of them are conscious ways, but you practice these things in all different ways. And if it's mixed with now a mental health need as part of that developmental practice, how is that going to impact moving forward? So that's a big consideration during this period of life. It also speaks to the high prevalence and expectation of this type of need during this period of life. And taken from a different study, this one was from one sponsored by Institutes of Mental Health. This one came from, it seems like, to me, this seems recent. 2010 seems recent, but it's not. This is the National Comorbidity Study, if you're familiar with that. They did an adolescent supplement back in 2010. They used 10,000 youth. They were randomly selected. These weren't kids who were referred by the school or mental health agencies or substance use agencies. These are randomly selected youth. Folks went out and did kind of a mini mental status exam on these 10,000 youth to see what the prevalence of mental health needs were. Half of all adolescents who were randomly selected, not identified as having needs, but half of all randomly selected adolescents were identified as having at least one diagnosable mental health disorder. If you have teenagers at home, you might think, well, that's kind of believable. But what's the real tale in that? Are half of all adolescents or half of all teenagers in the United States Living with a mental health disorder? Probably not. Actually, I go farther than that and I'll say, no, they're not. So when they set a new threshold, they said not just having enough symptoms that will check off the criteria to cross that line into diagnosis, but also then having the extra stipulation that they have to cross the line so that they've got some sort of severe impairment from these. And it cut that number in half, and it took it down to what we expect to see in the general population, that about 1 in 5 folks are living with an active mental health need, and that's what they saw in the adolescents, about 1 in 5. But I think the really important message in this is if you use criteria, and this was coming from the DSM-4, if you use criteria that are primarily normed on adults with adult expectations, and you apply that to try to understand adolescents, it's not a good or a clean fit. Adolescents do not have the consistent presentation that we expect in adults. They're not supposed to during that period of life. And so it makes understanding them very difficult. They presented the areas that they identified in 2 different ways. One, here's where they met enough criteria to be diagnosed, but without crossing that threshold of being severely impaired by those. And then they also presented it, here it is, crossing that threshold. Major depressive disorder was slightly in the lead as the most common of all crossing the threshold into severe impairment. But look at anxiety, and it really fits with the concept of what's going on during adolescence, right? It is an anxious period of life. Almost 1 in 3 adolescents are living with a lot of symptoms of anxiety, not necessarily crossing the line into severe impairment. So, I mean, almost to the point where we can say that this is part of the experience of adolescence, right? They were able to do it with ADHD. They could even do it with the externalizing disorders, which is interesting. Saying that, conduct disorder, I don't know how you cross that line. Is it severely impairing or not? Almost 7% crossed the threshold into checking all the boxes for conduct disorder. But was it causing a severe impairment in that kid's life? It's down to 2%. It's an almost inexplicable difference to me. They did not do that differentiation with substance use. They didn't want to say, yeah, this teenager is using drugs, but it's not severely impairing. So they left it at the standard threshold. So now, considering that diagnostic understanding, how we're going to conceptualize our understanding of adolescence, really thinking specifically of substances, which are frightening when it comes to working with adolescents. And you hear, yeah, I'm smoking weed every single day. I'm drinking on weekends. I'm binge drinking a lot. I've played around with Xanax or maybe some pain pills or something. It's very frightening to hear in an adolescent. I think it's more frightening to hear that in an adolescent than anybody. And we can really, it raises a lot of alarms, and then we start checking boxes without really digging into that understanding. Part of that is when we use the adult normed descriptions of and identifiers of substance use needs, substance use disorders, it doesn't fit cleanly, just like a lot doesn't, when we're trying to understand adolescence. So this is coming from ASAM, that's the American Society of Addiction Medicine, that has a very well-defined biopsychosocial understanding broken down into 6 different domains to help us really understand where areas of need and where areas of strength and overlap are with somebody living with substance use needs. And they have areas of the criteria that are very specific to adolescents. They consider them. I will argue, though, that their primary definition, this is their brief definition of addiction, doesn't necessarily fit so cleanly with adolescents. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. That's a very difficult fit with adolescents. When we think about what's going on developmentally, they are more sensitive to rewards. They are less risk averse. They're supposed to be. That's part of that evolutionary development that allows them to go out and find their own way. So how does this fit into it? It fits very well when we're considering adults. But I think that there's a lot of hesitancies and concerns here if we apply this directly to adolescents. Coming from the DSM-5 and their descriptions of addiction and addictive behaviors, a pathological pattern of behaviors related to the use of substances. That's difficult to define in most adolescents. Occasionally, you will work with an adolescent who clearly demonstrates a pathological pattern, but that's the exception, not the rule. Also talks about an important characteristic of substance use disorders is an underlying change in brain circuits. Well, how does that fit with adolescents who are actively changing brain circuits that may persist beyond detoxification? The persisting beyond detoxification very rarely fits with adolescents. It does with adults. Most of the conceptualization and really the criteria established. I'm going to go through those quickly and then I'm going to wrap up. Nicole, you're probably getting nervous that I'm going a little bit too long. Substance-related and addictive disorder from the chapter in the DSM mentions overall the diagnosis of a substance use disorder is based on a pathological pattern. Mentioned that. We need to cross the line. If you haven't worked in this chapter in a while, you might still be familiar with the 4, where all you needed was one criteria to be checked off, and then that would be the abuse. But they don't differentiate abuse and dependence anymore. Now they have it really in a stared fashion in terms of intensity of need here. So now we have to meet 2 criteria at a minimum to be diagnosed in this area. And the criteria, there's 11 of them, are grouped together. 1 through 4 talk about impaired control. 5, 6, and 7 are related to social impairments. 8 and 9 deal with risky use, and 10 and 11 are pharmacological, dealing with tolerance and withdrawal. These all have areas of problematic match in understanding adolescence. Thinking about the impaired control, that is a little bit defining about this period of life anyway, right? They are more sensitive to reward. They are more sensitive to social cues. They are less aversive to risk, more willing to take risks. So what does that look like when we're considering and measuring impaired control? It's also difficult to consider, are they more impaired in their control now than they used to be? Because this is an active period of development. Can you compare a kid who is 16 to when they were 8? Probably not fairly. You know, there are some underlying factors that you can, but it's still a pretty difficult measure and fit. Criteria number 3 in the impaired control specifically measures the person may spend a great deal of time obtaining the substance, using the substances, recovering from its effects. Occasionally, we will see adolescents who really spend an inordinate amount of time making sure that they have whatever it is that they're using, and more commonly than not, in terms of problematic identification, not overall use, but problematic identification is around marijuana. Criterion 4, craving is craving. And it was pointed out in a book, and I'll point it out in the reference section, that I really like. It's edited by Yafir Kaminer, that deals directly with co-occurring disorders and substance use considerations in adolescence. And coming from that text, they point out that craving has never been validated for adolescents. And if you work with adolescents who are using substances, you will hear them talk about cravings. Of the 11 criteria, this is the one that I think that I see endorsed by adolescents more than any of the others. But it's still a difficult fit when we're using adult framing. So from the social impairment grouping, these are especially difficult to match with adolescents because adolescents typically remain social regardless of what's going on, because it is such a hallmark of this period of life. The risky group using, the hazardous use kind of stuff. It used to be, well, if you're using and you know that it's dangerous, then there's an endorsement. That's not really the way it's framed anymore, but adolescents in general are riskier anyway. And so how do we match that? How do we understand that? So there's a lot of challenges in this. The last grouping is the pharmacological grouping. It's not often that we see tolerance develop in adolescence. Sometimes with cannabis, you will, and then that will lead into withdrawal. But the factors related to pharmacological pieces are a lot more rare and harder to understand in adolescence. And some of it may be genetically motivated as well, so or influenced, I guess I should say. So in our overall understanding and endorsing enough criteria, we really need to take the time to put on a special lens through which we filter things in understanding where the folks that we're working with are developmentally. And adolescence really adds layers, not a single layer, but layers to that challenge. So concluding thoughts in all of this, the rocket science statement of the day: adolescents are neither children nor adults, and they do have to be considered very specifically through the lens of where they are developmentally. So it can be very easy to over-identify symptoms, endorse criteria that have been normed either on children, and I'm thinking really across the entire text of the DSM right now, not just the substance use chapter, but really all of the areas of need. They've been normed either on children, or they've been more likely than anything normed on adults, and probably successful college students who volunteered. And so they're not a good, clean fit. Fitting into all of this, and this really fits into an echo that I'm involved with, a system of care echo that really focuses on adolescents and even younger ones. That all areas of need, and I think that part of the hypothesis is that inclusive. It might be a little bit big, but both substance use and mental illness might be traced to suboptimal acquisition of psychological regulation during childhood. And that fits in to a lot of the things that we talk about in the ECHO that I'm involved with, that system of care ECHO for kids with complex needs. Suboptimal psychological regulation during childhood that then gets expressed in a little bit different way during adolescence. And then in adulthood, we find personality disorders, right? So my argument is that during adolescence, we have a unique opportunity to provide support to people who can manipulate information in more logical ways. They can find areas of motivation, but there's still a lot of plasticity left for change to move forward in healthier trajectories. We do run the risk of over-identifying areas of need, over-pathologizing what's going on with adolescents, rather than recognizing that most of what's going on when I'm working with an adolescent is probably a normal expression of adolescence. So that's it. I want to point out in the resources and references, I don't think that the book is directly cited, but it is right here in this Fishman. It's one of the chapters coming from the book. It's substance use disorders and psychiatric comorbidity. It's edited by Kaminer, and it is from 2016. So it's a really good book if you are providing services that have inclusion of substance uses for adolescents. And I will say, based on prevalence measures, if you're working with adolescents, I guarantee you're working with folks who are using substances. Not all of them, but it's in the mix. And when it's overlooked, that can be problematic. So that was a little longer than 20 minutes. I apologize.